Good evening, everyone. My name is Ibrahim Saeed. I'm a cardiologist here at St. Luke's Mid-America Heart Institute, and it is a pleasure to introduce our four speakers today. I'm going to get started with Dr. Mazen Hanna. He is the advanced heart failure and transplant cardiologist at the Cleveland Clinic. He's the director of the Cardiac Amyloid Clinic at the Cleveland Clinic. Not only is he an expert involved in many of the seminal clinical trials, he's a wonderful physician, a passionate advocate for his patients. He's a cherished mentor for many trainees, including my partner, Brett Sperry. And it is with excitement that we introduce this talk on ATTR cardiomyopathy, a primer. Dr. Hanna, please take it away.
Okay, so I'm going to share my screen here. And really appreciate the kind introduction. I thank Brett Sperry for really putting this together, and the first 2 days have been wonderful. Today my topic is ATTR cardiomyopathy, pretty much a general overview. And we really have to contextualize this by first just reviewing what is amyloidosis. It's a protein misfolding disorder. And normally our proteins are in a three-dimensional or tertiary structure, and some proteins can pathologically misfold into a more linear shape with beta-pleated sheet formation. And then these misfolded proteins can aggregate and form what are called amyloid fibrils, which are rigid and insoluble and deposit extracellularly in tissues and organs, causing dysfunction. And regardless of the precursor protein that leads to the specific amyloid fibril, what they all have in common is when you stain the organ or the tissue with Congo red and visualize under polarized microscopy, you get this characteristic apple green birefringent pattern that's diagnostic of amyloid. And when you look at these fibrils under electron microscopy, they're rigid and non-branching, 7 to 10 nanometers in width and of indeterminate length. Now, although there's 30 different types of proteins that can cause various amyloid diseases, there's really two main types that affect the heart. And the first is AL, or light chain amyloidosis, which you heard about yesterday, which is a clonal plasma cell disorder, in which case the precursor protein that leads to the fibrils is a light chain, fragment of an antibody. And then the other main one is ATTR, or transthyretin amyloidosis, in which the precursor protein is liver-derived transthyretin. And then that type of amyloidosis can be subdivided into wild type, which is non-hereditary, and in a hereditary form. Now, I'd be remiss in at least not mentioning that there are some other rare causes of cardiac amyloidosis, but by and large, as a clinician, when you see something that looks like cardiac amyloid, it's going to be either AL or ATTR over 95% of the time. So what is transthyretin, or TTR? It actually used to be called prealbumin, and in 1981, the nomenclature changed to transthyretin as we learned more about the protein. It's a transport protein for thyroxine and retinol binding protein, hence the term transthyretin. It's mainly produced by the liver, although there can be some production in the choroid plexus and the retinal epithelium. And this liver-derived protein is a homotetramer. So it's made up of 4 identical monomers that are each 127 amino acids, each non-covalently bound together. And so let's drill down a little more on this tetramer. There's basically 2 dimers here with a dimer-dimer interface, and that's actually where the binding site for thyroxine is. Now, the majority of TTR is not bound by thyroxine, because thyroxine is bound by albumin and thyroid binding globulin the majority of the time. But the small proportion that is bound by thyroxine, it actually stabilizes tetrameric structure. Now, there's also a different binding site for retinol binding protein on TTR. So what happens in transthyretin amyloidosis? Well, the liver produces the tetramer, and in amyloidosis, the tetramer becomes unstable, whether it's the wild type normal protein with aging, or whether there's some kind of destabilizing mutation. At this dimer-dimer interface, you get dissociation and it breaks apart. And then these dimers break apart into the individual monomers, which then misfold and aggregate to form these small oligomers and amorphous aggregates, culminating into the mature amyloid fibril, which deposits in the heart, nerves, or both. Now, transthyretin, or ATTR amyloidosis, is subdivided, as we stated, into wild type and hereditary. And wild type, the median age at diagnosis is 74. Certainly we see patients in their 50s and 60s, but mostly they're in their late 60s and in their 70s. We don't know why there is no mutation here. We don't know why this protein misfolds in certain people. It's mainly a disease of males, much more common than females, about 90 to 10%, and it's often almost mostly in Caucasians, about 90%. When it affects the heart, you get heart failure, atrial fibrillation, or conduction disease. There's typically minimal peripheral neuropathy in this type. However, bilateral carpal tunnel syndrome, spinal stenosis, and biceps tendon rupture is actually quite common and can be important extracardiac clues. And the median survival is about 3 years, 3 to 4 years. Now, in hereditary ATTR amyloidosis, there's a single amino acid substitution in the 127 amino acid monomer. And depending on the mutation, there's going to be different median ages of presentation. And again, depending on the mutation, you may have cardiac manifestations similar to wild type, or you can have significant peripheral and/or disabling autonomic neuropathy, causing orthostatic hypotension, diarrhea, etc. You can get decreased opacities, carpal tunnel syndrome, and weight loss. And the median survival in this case is highly variable depending on the specific mutation. Now, the only way to distinguish between wild type and hereditary is to do TTR genetic testing. And that's quite easy to do because it's a very short gene. It's easy to sequence. It's a simple test of the blood or saliva with a turnaround of about 2 to 3 weeks, and we involve our genetic counselors. And it's very important to make the diagnosis of hereditary ATTR amyloidosis because there's been over 130 point mutations described. The disease is inherited as an autosomal dominant fashion. And typically those mutations that present with a more neuropathic phenotype have been dubbed familial amyloid polyneuropathy, or FAP. And those more of a cardiac phenotype, familial amyloid cardiomyopathy, or FAC. Now, it's notable that this nomenclature is kind of going by the wayside because the majority, if not all the mutations, have some degree of a mixed phenotype. This is a nice figure by Claudio Rapezzi showing the spectrum between neurologic and cardiac phenotype, and you can see the majority have a mixed presentation. Now, if you look to the right side of your screen with wild type as the more prototypic cardiac phenotype, there are a smattering of mutations that cause significant cardiac ATTR amyloidosis that all cardiologists need to be aware of. And the most common in the United States is V122I, or valine 122 isoleucine, in which at the 122nd position of the 127 amino acid monomer, there's an isoleucine instead of a valine. And the second most common is ALA60, where alanine is replacing threonine at 60 position, or originates from Irish descent and often has a mixed phenotype, but there's often significant cardiac manifestations. Now, something very confusing is the nomenclature recently on genetic testing has changed. There's a 20 amino acid signal peptide on the monomer that they're now including. So now you'll see instead of V122I, you'll see the letter P, then V142I. So it's the same exact mutation. They're just including this 20 amino acid signal peptide. And this is confusing a lot of people, saying, oh my gosh, this is a mutation I've never seen. So be aware of this nomenclature. I'm using the old nomenclature here for the rest of my talk. All these mutations have an age-dependent penetrance. Although you're born with the mutation, you don't present until adulthood. And as you can see, patients with wild type, the median age is in the mid-70s, whereas Val122 isoleucine in the African American population, it's more in the mid to late 60s. ALA60, the Irish mutation, in the mid-50s. And then there's a mutation in Denmark, Lu111 methionine, that actually presents median age in the 40s, much more aggressive. So it really depends on the mutation as to when you present on average. Now, regardless if you have hereditary or wild type ATTR cardiac amyloidosis, and for that matter, AL amyloidosis, what happens is you get diffuse amyloid fibril deposition. And you get thickening of the left ventricle and the right ventricle, and often without dilation of the LV cavity. And at times, the LV cavity can actually be small and crowded by that thickened ventricle. You universally get atrial infiltration, causing dilatation, interatrial septal thickening, and you can also get involvement of the conduction system, and mild to moderate thickening of the valves is not uncommon. And then you can also get deposition in the small intramural coronary arteries, which causes microvascular ischemia. It's important to note that some patients with ETR cardiac amyloidosis can have asymmetric septal hypertrophy, mimicking hypertrophic cardiomyopathy. Actually, a quarter of wild-type patients will have asymmetric septal hypertrophy, and a subset of those can have dynamic outflow obstruction. So you'll often see elderly patients misdiagnosed with hypertrophic cardiomyopathy that actually have ATTR cardiac amyloidosis. These are autopsy specimens of a normal heart on the left and a just incredibly infiltrated and enlarged heart on the right of a patient with ATTR wild type. And again, you can see the crowded chamber, the biventricular thickening causing stiff ventricles, and the dilated atria. So how do these patients present to us? Well, from a cardiac perspective, they present with heart failure symptoms, dyspnea on exertion, fatigue, and sometimes right-sided manifestations. And we often use the term HFpEF in that a lot of these patients have a normal ejection fraction. However, many of them have ejection fraction in the 40s. We talked about hypertrophic cardiomyopathy. Low flow, low gradient aortic stenosis in the elderly is not an uncommon presentation. Atrial fibrillation is quite common, and sometimes the first presentation is a cardioembolic stroke. Conduction disease leading to a pacemaker and angioabnormal coronaries. But it's the non-cardiac involvement that can often give a lot of clues and increased suspicion. Orthostatic hypotension is often seen in some hereditary mutations, not very common in wild type, it can happen. Peripheral and autonomic neuropathy can be severe in some mutations. Now, bilateral carpal tunnel syndrome is actually common in TTR. It's also seen in AL, but quite common in TTR, as is spinal stenosis and rupture of the distal biceps tendon. So how common is ATTR cardiac amyloidosis? It's actually not rare. It's much more common than we thought. About 25% of patients over the age of 85 on autopsy studies actually have TTR amyloid deposits. This is a nice study out of Spain where they looked at patients, 120 hospitalized patients with acute on chronic heart failure with preserved ejection fraction over the age of 60 with a wall thickness greater than 12 millimeters. And what they found, what they consented them to was a DPD scan, a scan, a nuclear scan that can be quite specific for TTR in the right context. And 13% of these patients had severe, moderate or severe uptake, and all of their genetic testing was normal. So basically, 13% of this population had wild-type ATTR cardiomyopathy. Interestingly, in this paper, 50% were women. And in this nice study by Maurer, who's going to be our next speakers, he looked at 151 patients who underwent TAVR at Columbia and did technetium paraphosphate, the same nuclear scan, but what we use in the US, on all the patients within 30 days, and found that 16% of them had significant uptake and all were wild type. And in fact, if you just drilled it down to men, 22% of the men actually had ATTR. And the phenotype was more that of low flow, low gradient aortic stenosis with worse diastolic function. So as far as extracardiac manifestations, carpal tunnel syndromes probably seen in about 30 to 40% of patients with wild type and can be the first presentation in many patients with hereditary ATTR. And what's fascinating about it is they tend to present 5, 10, and even 15 years before they have the cardiac presentation. In fact, oftentimes you'll ask a patient, have you ever had carpal tunnel? And they'll tell you they had surgery on both sides, one 6 years ago, one 7 years ago. And so Brett Sperry is going to talk about our study on carpal tunnel and the importance of asking this historical clue in when you see anybody with heart failure, particularly an older patient. As far as spinal stenosis and amyloidosis, this association was reported in the 90s. The prevalence in ATTR is 21 to 33%, and it's been much higher depending on how old the population is and if it's men. AL amyloidosis 8%, and it's, again, like carpal tunnel, a common presenting symptom, sometimes 5, 10 years earlier. And many of my patients will tell me they'd had spinal stenosis surgeries 10 years prior when I'm seeing them in the office and diagnosing them with ATTR cardiac amyloid. And in this case, the amyloid is found in what's called the ligamentum flavum, or the yellow ligament, which is right here. You get deposition, which then can cause a compressive entrapment neuropathy. In this study in Japan, they actually showed one of these specimens where you can see the Congo red amyloid deposits, in this case TTR, in the ligamentum flavum. And then finally, rupture of the distal biceps tendon is very much associated with wild type. In fact, Rodney Falk did a study where he talked to, I can't remember the exact number of patients, but quite a large number of patients with wild type, and asked for a history of just biceps tendon rupture, and 33%, 1/3, actually had this. You get this Popeye arm here. Under flexion, you'll see this bulge, which is an old biceps tendon rupture, and this is an acute distal biceps tendon rupture in a patient who had known ATTR cardiac amyloidosis. So anytime you see an older patient with HFpEF, any thickening in the ventricle, we should be asking these 3 questions. Do you have carpal tunnel syndrome, spinal stenosis, or a history of biceps tendon rupture? Going back to a few of these mutations, I wanted to go in a little more detail. Again, the V122I mutation seen in African Americans is the most common in the United States. The second most common is this Irish. I'll make a brief, fascinating mention of this V30M mutation. In this case, you have methionine replacing valine at the 30th amino acid. And there's an early onset variant seen in endemic areas of Portugal and Brazil, where patients can present as early as in their 20s with progressive sensorimotor and auditory polyneuropathy with little cardiac involvement. Yet the same exact mutation in certain areas of Sweden and Japan and sporadically worldwide can present late onset after the age of 50 and have more cardiac manifestations. So there's a really fascinating gene environment interaction. Now, as far as V122I, this mutation was first described in 1989 and 90 by Peter Gorovic, and then subsequently with Dan Jacobson and Joel Buxbaum. They've determined that about 3.5% of African Americans are heterozygous carriers for this mutation. It presents late onset in the 60s and 70s with restrictive cardiomyopathy, and the neuropathy tends to be mild in most of the cases. The median survival is only 2.5 years. Part of that may be when we're diagnosing these patients. There's a question of whether it's more aggressive than wild type. The male to female ratio is 70-30, so less male predominant than wild type amyloid, but it's still more male predominant. Now, if you look at the African American population, 37 million in the United States, and 3.5% of that is 1.3 million. And I just made this up. Let's say 1/4 of them are over the age of 65, so 325,000. Even if the disease penetrance is low as 10 to 15%, and we don't know the exact disease penetrance, probably have at least 40,000 African Americans walking around with this cardiomyopathy, often undiagnosed and misdiagnosed as hypertensive cardiomyopathy. The second most common mutation, ALIS60, originates in Northwest Ireland in an area called Donegal, where 1% of the population is positive, usually a mixed phenotype with cardiomyopathy and neuropathy. It's fascinating. Some patients will have horrific neuropathy and not as much cardiomyopathy, and vice versa, even within the same family. Median age of diagnosis here is in the 50s to early 60s. So in this transthyretin amyloid outcome survey, which was kind of a big epidemiologic database, if you look at the United States, the majority of the patients that contributed to this database were wild type, about 50%, and then about almost a quarter were V122I, and then about 10% ALIS60, with very little Val30 MET. But in Europe, the V30 MET mutation was the most common. And I do think these demographics will change as we get better at diagnosing wild type. So now that we know about ATTR cardiac amyloidosis and we know about the clinical presentation, what really prompts a suspicion is the echocardiogram. For those in the crowd that don't look at these, and this is a normal, what we call parasternal long still frame echo. This is the septum and the posterior lateral wall or posterior wall. And a normal wall thickness is about 1 centimeter, up to 1 centimeter. This is the left atrium, this is the right ventricle, aortic valve, and aorta. You look at an amyloid heart, what happens is the amyloid fibrils deposit around the myocytes and thicken the ventricle. So here, this septum is probably at least 2 centimeters, so twice as the normal thickness, as is the posterior wall. Tends to be diffuse, although there can be some asymmetry. The RV is thickened, which is an important clue, and dilated atria. And when you look at these hearts, biventricular thickening and biatrial dilatation with some thickening in the valves are very important clues. And these hearts are stiff, and so you get what's called diastolic dysfunction, sometimes a restricted filling pattern. And it's often looking at the echo with the electrocardiogram that can also further strengthen the suspicion. Now, I'm showing you a classic low voltage EKG seen in cardiac amyloid, where you have less than 5 millimeters in all the limb leads, less than 10 in the precordial leads, and what we call a pseudo-infarct pattern. It looks like this patient's had a previous anteroseptal MI. However, as Matt Maurer always said, if we're going to wait to diagnose patients when the EKG looks like this, we're in trouble. This is a very late finding. And in fact, only about a quarter to a third of patients of ATTR cardiac amyloid have true low voltage on the EKG. And in fact, 10% meet criteria for LVH. And this is an example EKG of an 81-year-old white male with biopsy-proven wild-type ATTR cardiac amyloid. And you can see, particularly V4 through V6, he meets criteria for LVH with strain pattern. So the absence of low voltage should not dissuade you. And in some cases, LVH should not dissuade you if everything else is pointing towards amyloid. Now, how do we diagnose this? This is going to be discussed a lot more on Friday, so I'm not going to spend a lot of time on this. But we used to go to endomyocardial biopsy first. And we use a transjugular approach. We basically go onto the right ventricular septum and take these 4 or 5 booger-sized pieces of myocardium. However, there's a rate of perforating and causing tamponade of a bit under 1%. When you do get the specimen, you see this H&E stain shows this pink type of amyloid material around the normal red myocytes. And when you stain it with Congo red, you confirm it's amyloid, but then it's exquisitely important to subtype it as ATTR, AL, or another type using either immunohistochemistry, but the gold standard mass spec, because that's going to determine your further testing, prognosis, and treatment. So in the old way, we would basically do the biopsy, and if it was TTR, you do genetic testing, and then you determine if it's wild-type or hereditary. However, there is non-invasive imaging in labs that in a significant number of cases, you can obviate the need for a cardiac biopsy if done appropriately. So the most important thing, you cannot think of ATTR cardiac amyloidosis without thinking of AL amyloidosis. So there are important blood tests that you need to order to rule out AL, which is a serum-free light chain assay, and immunofixation of the serum and urine, which was described yesterday in detail. The problem with an SPEP and a UPEP, electrophoresis, it's not sensitive enough in and of itself to pick it up. So it's crucial to do the right lab testing. And this is an example of a normal serum-free light chain ratio where the kappa and lambda are almost equal. And here you can see the lambda is much, much higher than kappa with an abnormal ratio. So that lab testing, in addition to some non-invasive tests, can be useful. Now, cardiac MRI and strain echo can help, tell you that this is very likely amyloidosis, but it's not completely diagnostic, and it also doesn't tell you which type. So what's really revolutionized diagnosis are these nuclear bone scans, where it was noted that patients with amyloid can get uptake in the heart, in addition to areas of the bone, and more so in ATTR than AL. In the right context, if you see the significant uptake in the heart confirmed by SPECT imaging, this can be very helpful. And so there's this grading system with these technetium pyrophosphate scans, which we hear about on Friday, which basically, if you have grade 2 or 3 uptake confirmed by SPECT, and you have what's called a heart-to-contrail ratio that's higher than a certain amount, in the setting of negative monoclonal lab testing, meaning you've excluded AL, because remember, AL can give you uptake, you can actually diagnose ATTR non-invasively. So when you're in the clinic and somebody comes to you with symptoms, and you see echoes like this, and you see EKGs that may be suggestive, you got to ask them about carpal tunnel, about spinal stenosis, biceps tendon rupture. Do they have neuropathy? Do they have orthostatic hypotension, diarrhea? Are they African American? Are they an elderly white male? Are they from Irish descent? All these things have to kind of be contextualized and see the whole patient. In this case, the upper right is amyloid, and probably the biggest mimic of amyloid heart disease is hypertension with renal failure. So I'm going to end in the last 5 to 7 minutes with just a couple cases. This is a 78-year-old African-American female with a history of hypertension and a mildly reduced ejection fraction of 45%, referred to me for shortness of breath. If you looked at her electrocardiogram, she actually does not have low voltage. She almost has borderline LVH based on AVL. She's got a couple PVCs. But what struck me when I looked at her echocardiogram was thickening of the left and right ventricle. The atria were very large, and there was thickening of the mitral and tricuspid valve. Now, in this case, the LV was a mildly dilated. It typically isn't an amyloid, but sometimes we'll see that, particularly in this mutation. So in this case, we applied our algorithm. We ordered the right test to exclude AL, which is the serum-free light chains and serum and urine immunofixation, and they were all normal. And we did the technetium pyrophosphate scan, and you can see very significant uptake in the heart, more than the rib, and confirmed by SPECT imaging. So this is actually diagnostic of ATTR cardiomyopathy. So the next step, all of you should be thinking, is genetic testing, and she had the V122I mutation we see in African Americans, and so she was non-invasively diagnosed with hereditary transthyretin cardiac amyloidosis, and unfortunately there were no treatment at that time, and she died within a couple of years. We did, however, offer family genetic testing, and that's a very important point. So 81-year-old white male, he's diagnosed with diastolic heart failure and paroxysmal AFib. He has a history of bilateral carpal tunnel syndrome, surgery about 6 years prior, spinal stenosis, surgery 8 years prior, and he has a history of a biceps tendon rupture. He has myelodysplastic syndrome with platelets in the 60s, metoprolol 25, he's on warfarin, and his blood pressure is 128/65. This is the EKG I showed you before. This gentleman has criteria for left ventricular hypertrophy. However, if you look at the 1.6 centimeter walls, it seemed a little bit out of proportion to his blood pressure. Although he had a history of hypertension, his blood pressure was normal, and he had a pericardial effusion. And if you look at his apical four-chamber view, you see these very dilated atria and these biventricular thickening. So this prompted us to work him up. Now, he had platelets in the 60s. We didn't want to biopsy this guy. By the way, he had this apical sparing pattern that you'll hear more about on Friday, which was also suggestive. So we did the free light chains, and you see a very mild kappa predominance with a very mildly abnormal ratio. No M protein immunofixation. A lot of uptake on the technetium pyrophosphate scan on the heart, confirmed by SPECT imaging. You can see all this orange part is all uptake. And then we did genetic testing, and there was no mutation. So the question is, can we diagnose this patient with wild type TTR with this abnormal kappa lambda ratio? And in the question and answer session, I'd like to review this more, because the biggest concern is missing AL, which is a tragedy. And I'd like to, in the question and answer session, maybe we can bring this case up and determine how many people would absolutely biopsy this patient, and how many people would say this is so mildly abnormal due to renal dysfunction, they would ignore it, which can be dangerous in some cases. Last case, I promise I'll wrap it up. 55-year-old white male, history of hypertension and hyperlipidemia. 2007, at an outside hospital, was diagnosed with complete heart block. They didn't know why. They put in a dual chamber pacemaker. By 2008, he was having recurrent ascites and shortness of breath and was getting GI workup. We were consulted. Here's his echo. Now, you'll have to trust me, but the septum and posterior wall are over 2 centimeters, highly thickened, small pericardial effusion, which is not uncommon in amyloid, big left atrium. Here's his apical four-chamber view. You can see kind of a small LV cavity, biatrial dilatation, pericardial effusion, and he had what's called severe diastolic dysfunction on the echo. Now, when we further talked to this gentleman, he actually is from Irish descent. His mother had a history of amyloidosis, and we did a heart biopsy, and he had TTR amyloid and had the ALA60 Irish mutation, and actually on further inquiry had some peripheral neuropathy. He underwent a combined heart and liver transplant in 2009, is still alive today, and that same year his sister came to us and was worried that she needed to be tested, and we indeed tested her for TTR, and she had the same mutation. We followed her, and by about 7 years later, we were following her for imaging and following her with symptoms, and she ended up starting to develop some patchy LG uptake on MRI, and then by 2017, she had significant uptake confirmed by SPECT. So she had really no cardiac symptoms, but we detected this by imaging her closely and put her on treatment. And this gentleman's 41-year-old son then came to me a few years ago and said, I need to be tested too. He was positive. Mild dyspnea exertion, mildly elevated NT-pro at best, He had bilateral carpal tunnel syndrome. His echo showed mild increased wall thickness, nothing in your face, normal EKG, relatively normal strain, but he had grade 2 uptake in the technecian paraphosphate scan confirmed by SPECT. We didn't feel we needed to biopsy him when we put him on treatment. So that's an example of the implications for the family. So I'd like to summarize that there are red flags for cardiac amyloidosis we should be all aware of, and that's both for AL and ATTR. Looking at wall thickness greater than 1.2, thickening of the right ventricle, free wall and valves, intolerance to beta blockers and ACE inhibitors we didn't talk about, bilateral carpal tunnel syndrome, and specifically for ATTR, any white male over the age of 60 with, quote, HFpEF, and has a history of carpal tunnel or spinal stenosis or biceps tendon rupture, that's a very important clue. Any African American over the age of 60 with HFpEF, without a history of hypertension, or even with a history of well-treated hypertension with thickened walls, we have to think about it. A new diagnosis of hypertrophic cardiomyopathy in an elderly patient, a low flow, low gradient aortic stenosis in the elderly, and a family history of ATTR. So I think if we look at the epidemiology, we know the amount of diagnoses, particularly wild type, is rising. We now have a non-invasive diagnosis ability if used correctly. And you'll hear from Matt more pretty soon about the emerging treatment options, something we can finally treat. So I thank you for your attention, and I don't think we have time for questions, but possibly we can do it at the very end.
Well, we do have time for questions, hopefully at the end, but
yeah, perfect.
Thank you very much. That was just fantastic, that entire review. So please stick around. We'll have some questions towards the end, and I'm going to move on to our next speaker here, who is Dr. John Eatman. Dr. Eatman, would you mind sharing your screen? So a little bit about Dr. Eatman. He is a neurologist here at the St. Luke's Marion Block Neuroscience Institute. He did his training at the University of Texas Health Science Center in Houston. He also spent an extra year doing advanced neuromuscular medicine training. And he's our go-to guy here for all things neurological in the setting of amyloidosis. And, as cardiologists, we work a lot with hematologists and trying to understand subtleties of this. But one of my personal areas of deficiency is neurology and neuromuscular medicine. So I'm really looking forward to this talk. So John, would you mind taking it away?
All right, sorry about that. I'm not a huge computer person when it comes to Zoom. So this talk is going to be about peripheral nervous system manifestations of hATTR. And that's a little bit different than what was on the schedule, but I tried to narrow this focus to make sure that we get in the allotted time. And really this is directed towards non-neurologists to kind of give an explanation of what we do and how we evaluate patients. So for the pretest, what is the most common hATTR mutation in the United States? Do we have a poll?
No.
You guys in the chat can enter in what you think here.
How do I pull up the chat?
I can see it. So yeah, most people are saying B.
Okay, good. So in the United States, it is B. What is it in the world?
And feel free to post through the chat. Mm-hmm. Yeah. People are saying A.
Okay, perfect. All right. So this is the next question. What is the best way to describe an EMG nerve conduction study to a patient? Let's see here. Where's my screen doing this?
Let's do the, yeah, there you go.
Okay, good, get rid of this. The first part of the test involves simulating nerves and recording other parts of the nerve or muscle to determine the health of the nerve compared to age-matched controls. The second part of the test involves using small needles placed in the muscle to record the muscle arrested contraction. Or B, the doctor is going to shock you with needles. So this is just something that I hear all the time. It's almost exclusively B. And I don't know if the physician orders the test, describes it correctly, and then the patient just hears needles and shocking and then just conflates the two. But please don't tell patients that I'm going to shock them with needles. So this is what we're going to talk about today. The different types of peripheral neuropathies and their patterns of involvement. And this is a general overview because some of the next things we're going to talk about will make sense only if we have a general overview of neuropathy. Evaluating neuropathic symptoms and signs. Electrodiagnostics of peripheral neuropathies, including shocking with needles, and patterns of hATTR mutations that affect the peripheral nervous system. So as you already know from previous meetings, there are a wide variety of known mutations. We're going to touch on some of the more prevalent ones and talk about what their peripheral nervous system manifestations are and how they're different. So the challenge for the non-neurologist is when you see these patients in clinic is to start to ask questions and try to identify peripheral neurologic symptoms to allow appropriate referral and treatment. So let's talk a little bit about the different types of peripheral neuropathy. Peripheral neuropathy is more than just prescribing gabapentin. There's multiple different types and different patterns that we see. So we start with taking a look at the different systems involved. So is there a prominent sensory symptom? Is it a painful sensory symptom? Is it a painless sensory symptom? This is a old pharmaceutical ad, and I have a particular interest in pharmaceutical ads because I find the way that they convince people somewhat fascinating. There's no way you can look at that foot and not feel uncomfortable. And so but that is a described thing that patients will talk about is, hey, it feels like there's ants crawling on my feet. No, that's not technically painful, but I don't think it's a sensation any of us would voluntarily want. Are there motor symptoms? Is there prominent weakness? Are there autonomic symptoms? Sometimes the autonomic symptoms are a little bit more difficult to tease apart. For example, the gentleman in the picture here, that's me if I don't have my sport coat on right now. You know, profuse sweating. Are they sweating more than they used to? Or sweating less than they used to? Are they having a lot of alternating diarrhea and constipation? Later on, we're going to talk about how specifically the GI symptoms relate to differentiating different types of amyloidosis from other neuropathies, including inflammatory neuropathies, for which they're frequently misdiagnosed. And then we look at the distribution. So we see three different distributions here. We see a generalized, we see distal and proximal in the middle, we see distal to the left, which would be your typical link-dependent neuropathy. We see focal and multifocal neuropathy. So over here we have a patient with two mononeuropathies or multiple mononeuropathies. So let's talk a little bit about the nerve itself. So the nerve consists of the cell body, the myelin, the in-between myelin are these nodes, which are very rich in ion channels. And then there is the axon itself. So essentially, the myelin allows a increased speed of transmission by allowing saltatory conduction, jumping from one node to the next. When you have an issue involving the axon, this is more of a distal dying back concept. And as you can see here, the proximal myelin is maintained. When you have a neuronopathy, which indicates pathology of the actual cell body, you can see that you get deterioration along the entire length. And then in segmental demyelination, you see that areas of demyelination intersperse with areas of myelination, but depending on how severe the areas of demyelination are, you can get failure of conduction, conduction block, and of course, overall slowing of conduction. this is another way to take a look at how the different nerves differ based on their size, their myelination, and what their function is. So on the left, we have the very large alpha motor neurons, which go down from the spinal cord and innervate the individual muscle fibers. And then for our sensory systems, we have the large myelinated fibers, which are touch, vibration, position, and proprioception based on lamellar corpuscles, Merkel's receptors, Meissner corpuscles. Then the thinly myelinated and unmyelinated sensory axons, the A delta and C, which are often open-ended or free nerve endings. And then your thinly myelinated and unmyelinated C fibers, which are mainly autonomic, which involve multiple things: heart rate, blood pressure, sweating, GI function, and other things. And I would emphasize over on the right side, these can be very, very important to identifying patients with amyloidosis related neuropathy versus some of the other neuropathies. So let's talk about when you see this patient in your clinic. So what type of questions are you going to ask, and what type of things will they likely complain of, since they're not going to walk in and say, hey, I've got a distal axonal polyneuropathy. You've got to kind of tease it out of them. So for neuropathic symptoms, there are small fiber symptoms: distal paresthesias, dysesthesias, allodynia, hyperalgesia, spontaneous pain, that has to do with a shifting of the pain threshold in the normal pain response. For large fibers, you'll get impairment in light touch, vibration, and position sensation, as well as distal lower motor neuron weakness, and gait dysfunction is a major complaint. Autonomic is basically multiple organ systems that are innervated by autonomic nerves, causing multiple things. Erectile dysfunction is extremely common, orthostatic hypotension, alternating constipation and diarrhea, nausea, vomiting, early satiety, and sweating changes. So going back to what we're seeing here, essentially, the pathology is spread out amongst all different types of the nerves, myelinated, unmyelinated, and kind of what the complaints are points you towards where the pathology may be. Part of determining what the underlying process might be is the tempo, acute, subacute versus chronic. So in patients with amyloidosis, we'll generally follow a subacute or chronic pattern, in that acute would be generally less than 4 weeks, subacute 4 to 8 weeks, and then chronic is 8 weeks. It is a progressive pattern rather than a monophasic or relapsing pattern. Sensory symptoms that are very common are burning pain in feet, and especially if you ask the patient, when you lay down at night, do you have burning pain in your feet? That tends to be a very common complaint. They might not just come out and say that. Another big complaint is uncomfortable sensation when sheets are rubbing against the feet. And this, like I said, is another one that you might not get unless you ask them. Tight sensation in the ankles and wrists is a common complaint. Dull or poorly localized aching is a common complaint. And then loss of balance and incoordination, which they might describe to you or they might not. But one question that I like to ask patients is, when you wake up at night to go to the bathroom, are you having more issues maintaining your balance at night when you're walking in the dark, or when you are taking a shower and you are putting soap in your hair and you're closing your eyes, unless you're like me and you use the baby shampoo? Do you have more problems maintaining your balance? And sometimes when phrased like that, patients will say, actually, now that I think about it, this does seem to be kind of a more description of my symptoms. Now, these sensory symptoms kind of run the gamut of small fiber versus large fiber, burning pain in feet, and uncomfortable sensations are small fiber symptoms. kind of dull, poorly localized aching is polymodal C fibers, and so on. So talking about the motor symptoms, so of course we're going to do an examination that tests formal motor strength, but when you're asking the patient about symptoms, they may complain about certain functions that are more difficult for them, and that will help you localize where the weakness is most prominent. Something that you will see in a lot of patients with neuropathy secondary to hereditary amyloidosis is the steppage gait. So we see over here that gentleman on the right is not dancing. He is actually trying to sweep his foot up to prevent his toe from catching due to weakness of the tibialis anterior and fibularis longus, causing his foot to drop and being unable to dorsiflex appropriately. So that is usually one of the most early things that I hear from my patients who have motor involvement is, you know, maybe they don't say they feel weak, but then when you ask them, they're like, okay, I guess I've fallen twice in the last couple of months and I've been tripping on my toes. It gives you an idea that they're perhaps not dorsiflexing their toes enough. Other things that you can see are difficulty manipulating objects. Dropping objects is very big, especially in carpal tunnel syndrome, which Dr. Sperry is going to talk about in a minute. And muscle wasting. While muscle wasting can occur due to multiple conditions, neuropathy and axonal loss can precipitate this as well. So as we discussed earlier, looking at small versus large fiber, the neuropathic signs that you look for on examination for small fiber are sensitivity to pinprick and decreased sensitivity to temperature. Now, of course, back in the day, they used these old roller pinprick sensation. We don't use those anymore. We use sterile pinprick sensation. Large fiber would be decreased sensitivity to vibration tested with the tuning fork at the joint. And then proprioception deficits also tested at the joint itself. Those testing changes in muscle length and stretch receptors, muscle spindles, and decreased deep tendon reflexes, which can be either a sensory or motor phenomenon or both. And as you can see here, the examination really focusing on the distal extremities and a lot of the sensory modalities. I don't hold fire up to the patient, nor do I have a ice cube, but generally the idea is similar. So one of the ways that you can tell a lot about a patient is by looking at their feet. I constantly get referrals for Charcot for a person who has a Charcot foot, as you can see on the left. Now, a Charcot foot is essentially arthropathy secondary to sensory loss that was first described by Charcot in 1868, but was actually not seen in patients who have Charcot-Marie tooth, but patients who had syphilis. And the most common cause of Charcot foot in the United States is diabetes, thought to be a cycle of inflammation without pain, temporary osteopenia, fractures, joint destruction, collapse of the longitudinal arch, and as you can see, the rocker bottom deformity. On the right here, you can see the typical finding you would see in a patient who had Charcot-Marie tooth neuropathy, which is not a Charcot foot, but high arches and hammer toes, which are thought to be basically an imbalance of strength in foot and ankle, and weak everters are overpowered by stronger inverters. Now, I show you these not necessarily because these are common findings in hereditary amyloidosis patients, but to show you that these are common findings in neuropathy patients and have been described in hereditary amyloidosis patients as well. So a lot of people would see that foot on the right and say, well, that's, especially if it's that severe, well, that has to be, hereditary neuropathy. But actually, that picture is from an article of a person who had CIDP and spinal stenosis. So you kind of have to keep an open mind despite seeing things which may be typical for certain disease patterns. Here we see atrophy of the APB, which is a very common finding in patients who have carpal tunnel syndrome. In patients who don't have any kind of sensory loss, can also be seen in ALS patients with the typical split hand. And from a neuropathic standpoint, atrophy from neuropathic disease can result, as we see over here to the left of the picture, we have normal motor axons innervating different muscle fibers. Whenever you lose one of those axons, collateral sprouts will develop from a nearby motor neuron. However, there are limits to how they can compensate, eventually leading to progressive denervation and then atrophic changes. So let's talk a little bit about electrodiagnostics. So this is, because of the limited time I have, we're going to touch on nerve conduction studies only. I'm not going to touch on EMG or QSART or the thermoregulatory sweat test. So here we have a picture of an engineer, Irvin Smith, at Mayo Clinic with one of the first EMG nerve conduction study machines. He was actually an electrical engineer. But it was Dr. Lambert's lab in the 1950s who developed this. And the general principles here are providing a stimulus, recording lower down the depolarization. And as you can see here, they originally used an oscilloscope. And above that is a Polaroid camera that they would have to flip down on a hinge and then synchronize with the stimulus to catch the waveform, since oscilloscopes didn't have a save feature. So a very quick basics of nerve conduction study: a depolarizing stimulus is applied, producing a compound muscle action potential, which is recorded further down due to activation of muscle fibers that are supplied by the nerve that is stimulated. For sensory nerves, you get a sensory nerve action potential, as you can see over here on the right, which results in a depolarization of individual nerve fibers. In axonal loss, because we have a loss in the actual, essentially the wires, and fewer functioning axons, we see a reduction in the amplitude of response. And then a slowing, because remember, myelin is responsible for the speed of conduction. The slowing is not necessarily due to loss of myelin, but loss of the fastest conducting axons. In demyelinating neuropathies, we have a reduction in the conduction velocity. However, the reduction in amplitude is not as significant unless there's conduction block and failure of conduction. So this kind of brings us to one of the most important concepts here, which is, patients who have hereditary amyloidosis are often misdiagnosed. And in an Italian study where they studied 51 misdiagnoses, the most common misdiagnosis was CIDP, which is an inflammatory demyelinating polyneuropathy. And so they went back and took a look at the electrodiagnostic testing for these patients, because patients with amyloidosis generally have an axonal sensory motor polyneuropathy and should not have as prominent slowing, and found that because of the overlap between conduction velocities for demyelinating axonal polyneuropathies, many of these patients had studies which were borderline or axonal, but were diagnosed with CIDP after electrodiagnostic testing anyways. And of those patients who were diagnosed had lumbar punctures showing elevated protein, which is, of course, a characteristic of CIDP, but it does not distinguish between CIDP and hereditary amyloidosis. One of the ways that they recommended in trying to determine, based on nerve conduction studies, to be more suspicious would be looking for more axonal loss in conjunction with these patients compared with CIDP patients, even ones who had a more chronic disease pattern. So finally, I'm going to wrap up here, and we're going to talk about some of the hereditary TTR amyloidoses, the common ones, and how they affect the peripheral nervous system. So this is from a study where they took a look at neurology clinics, cardiology clinics, and then the United States versus the rest of the world. And of course, you can see in the United States, the Val122I being much more represented, whereas in the rest of the world, Val30Met is more represented. But if you look at the neurology sites, Val30Met is far more represented, whereas in cardiology site, get another mixture of different cases. And that has to do with Val30Met and the effects on the peripheral nervous system, which might guide a person to presenting to or going to a neurology clinic. So Val30Met, of course, is the most common hereditary amyloidosis mutation. And there is a bimodal pattern, and it's beyond the scope of this lecture, but essentially there are pockets of patients in Portugal, Sweden, Japan, and Brazil who have Val30Met. And especially in Japan, they have found that patients can have an identical mutation. However, some patients present with early onset and some patients present with late onset symptoms. And much of the determination of whether a patient presents with early onset versus late onset symptoms has to do with whether or not they come from an endemic area. Endemic being one of the areas in Japan that has more mutation as a percentage of the population. And I think that in Japan, I think there's 2 or 3 areas. For the same is true of Portugal. In Sweden, Val30Met patients tend to have the later onset symptoms versus the early onset symptoms, even in some of the endemic areas in Sweden. So the early onset is going to be predominated by pain and temperature sensation and early autonomic symptoms. So I can't emphasize this enough. The early autonomic symptoms can be a very good clue when you're evaluating a patient that perhaps this is more than your typical peripheral neuropathy. And especially GI autonomic symptoms, symptoms of diarrhea, alternating constipation, nausea and vomiting, feeling full, weight loss. They should not have light touch vibration and position sensitive changes until later on in the disease, and then finally, as it progresses, motor involvement. For late onset disease, they will often find they will have panmodal early distal lower extremity sensory motor symptoms where pain and temperature are not as predominant in the picture. So more large fiber and small fiber as opposed to more small fiber and autonomic symptoms. Initially in the late onset patients, autonomic symptoms may be mild and only something that if you ask specifics, the patient might bring out some recent GI distress. For Val122 isoleucine, this is the most frequent mutation in the United States. It's most commonly associated with a cardiac phenotype, but it can be associated with a heterogeneous neuropathic presentation, carpal tunnel syndrome being very common, and then mild to severe small and large fiber sensory neuropathies and autonomic neuropathies. So there was a paper that was in neurology in 2015 that studied this. Heart failure was the first manifestation in the cohort of 17 patients. However, 10 of the 17 patients had both large and small fiber neuropathy symptoms, and 6 had small and autonomic symptoms. So finally, THR60-ALA, most common mutation in the UK. It is more commonly associated with cardiac and autonomic phenotype, first described in the 1980s as the Appalachian amyloidosis from New York, but then they found out that this was actually from Donegal in Ireland, where 1% have the mutation. For the neuropathic symptoms, tend to be autonomic symptoms being the most prominent, and almost half of them having them with hypotension, diarrhea, constipation, erectile dysfunction. So I know that was very quick, and I'm going to hand it off to Brett Sperry here. I think I took a little bit more time than I intended, but I apologize, and I will answer questions at the end.
No apology needed for such a great presentation. That was really good. We talked about getting an applause track. We'll do that next time. You know, I want to, we're going to get to some questions here. I'm going to, am I still on? Just saw a meeting end. Yeah. So I'm going to introduce our next speaker here, which is Dr. Brett Sperry. It's a pleasure to introduce him. He's a colleague and a friend of mine here at the St. Luke's Cardiac Amyloid Clinic. He did his early work at Georgetown, his undergrad work in economics, his medical school there, his internship and residency before coming to the Midwest. He went to Cleveland Clinic for his general cardiology fellowship, and then for his heart failure transplant fellowship. He is the author of many, many, many works of literature on amyloidosis, and is the brainchild behind this amyloid conference that went from something regional to something international. I was going to say viral, but I think that's too soon. He has a very unique perspective because he's both a heart failure transplant cardiologist and a nuclear cardiologist, and we've been so fortunate to have him when he joined us in 2017. So Brett, take it away. This is your show now, as always has been.
Thanks, Abe. Well, your introduction is probably going to be as long as my slides here. I just have a few slides here, and I just wanted to piggyback off of what John Eatman was saying here. You know, we have non-cardiac red flags or symptoms of amyloidosis, and we talked about neuropathy, and as well as how a lot of these GI symptoms can be a manifestation of an autonomic neuropathy. Dr. Hanna spoke about some of these soft tissue manifestations, so I won't necessarily go into them as much, but I do want to talk about carpal tunnel syndrome, which is a study and a issue that is dear to our hearts, because we think that it's a good way to get an early diagnosis for patients if we can get them at the time of carpal tunnel syndrome surgery particularly. So this is a study that we did that was published in the Journal of American College of Cardiology in 2018. And I'm going to look at the anatomy here just for a second, and then I'm going to talk about the study and why I think it's important to potentially screen these patients. So if you can see the picture on the right, this is a cross section here through the wrist, and you have some of the bones of the wrist here, and I'm going to explain this in a non-hand surgeon way that hopefully most of us can understand. And so this is the carpal tunnel, and these are the contents of the carpal tunnel. Some of these are tendons, and then there's the median nerve here. This is covered by the flexor retinaculum, which is the transverse carpal ligament. So if there is proliferation of various things within this carpal tunnel or of this flexor retinaculum, this can cause these compression type symptoms. So here is a video, and I'm not entirely sure how choppy this is going to be over the computer here, but this is actually a video that Bill Seitz did, who's is a hand surgeon, chief of hand surgery at Cleveland Clinic, and worked with us in the study. And what you initially saw here, and I'll go back to the beginning, this is the median nerve that he is mobilizing and moving to the side, and underneath that are all of the tendons within the carpal tunnel. And we published this video as part of a review article that we did. And so what he's doing here is he is snipping off the tenosynovium, which is the covering of the tendons as they come through the carpal tunnel. And really a good debulking of this tenosynovium is important in order to decrease symptoms of carpal tunnel syndrome and to prevent or decrease the risk of this happening again. So you can see how much tissue he's taking off here. So this tissue is normally going to come out during a carpal tunnel surgery. And so it is very easy, therefore, when someone does an open carpal tunnel release surgery like this one, to remove that tissue, send it to pathology, and then screen for amyloidosis. So this is the study design. We took patients who were undergoing carpal tunnel release, men over 50, women over 60. I don't know that those exact ages matter completely, but just people within that age range. And we excluded patients who had were on dialysis or had rheumatoid arthritis, known trauma to the hand, or a known history of amyloidosis. And then we sent this tenosynovium tissue to the pathologist to put Congo red stain on and see if it was positive or negative, to see if they had amyloidosis. In cases that were positive, they went for mass spec, and then we did a comprehensive cardiac workup, including echo with strain and technetium pyrophosphate scan. And then if these were negative for amyloidosis of the heart, then we planned on following, either way, we planned on following these patients for several years afterward to see if they developed amyloid of the heart. So we found that around 10 out of 98 patients, so around 10%, had amyloid deposits in the carpal tunnel. 7 had a TTR subtype. 2 actually had genetic mutations. 2 were light chain subtype, 1 kappa, 1 lambda. 1 was unspecified, which was presumed to be ATTR, or TTR rather. Again, 2 hereditary mutations. All the biopsy positive patients had bilateral symptoms. So that's important. And then 2 patients of this cohort actually had cardiac involvement at the time of this carpal tunnel surgery. And so if we go to the next slide, here's an example of a patient who, this is the H&E stain and then the Congo red stain. Here's his EKG, which looks pretty normal to me. And again, his echo, which was probably would be read as unremarkable. A strain pattern here, slightly lower in some of the segments than normal, but overall global longitudinal strain was normal. But here's his PYP scan, so clearly markedly positive here. So this is a patient that we think we found early who had cardiac amyloidosis, and again, this was at the time of hand surgery, before he really had any cardiac symptoms. There's another patient who had active AL amyloidosis and had seen 2 or 3 doctors already trying to get this figured out, and was still in the process of trying to figure out what was going on. And so we diagnosed this based upon a biopsy during her carpal tunnel surgery. So here's the algorithm that we developed, which is basically that if you have 2 characteristics from tier 1, which just means you have bilateral carpal tunnel symptoms and your age is males over 50, females over 60, then we would recommend a biopsy here of the tenosynovium. There are some issues with implementing this and workflow. It's a multi-departmental algorithm that we need to get buy-in from hand surgeons, and we need to figure out how to institutionalize this in each department. In my discussions with hand surgeons, it's not something that they have seen or heard about before, probably because it's something that presents many years later. It presents usually, like Dr. Hanna was saying, 5 to 15 years later. And so so it is not something that they're actively seeing, or patients that are actively diagnosed with. So definitely challenges to getting this implemented, but I think that this, as we talk about ways to be able to allow patients to get a diagnosis early, while some of these medications hopefully can work really well, that Dr. Maurer will talk about next, really getting them diagnosed early and getting them on treatments for them before they develop symptoms is paramount. So I'll stop there and then turn it over.
That was great, Brett. Short and sweet, but a lot of content in there. Okay, well, now it's my pleasure to introduce Dr. Matt Maurer here. Let me give you a little bit of background about him. So Dr. Maurer, I'm sure you've all seen his name in the literature already. He's the medical director of the HCM Center at New York Presbyterian Hospital and Columbia University Medical Center. He's a general internist and a geriatric cardiologist. You can see his interest in this finding now. He has advanced training in heart failure and cardiac transplantation. He's received multiple grants from the National Institute on Aging to study cardiovascular changes in older patients. and he specialized in the care of patients with heart failure with preserved ejection fraction, including patients with fake hearts. Dr. Maurer is an associate professor of medicine at Columbia University College of Physicians and Surgeons, where he directs the Clinical Cardiovascular Research Laboratory for the Elderly at the Allen Hospital of New York Presbyterian Hospital. He was the lead author for the Attract trial, which was for tafamidis. You will see he is a very astute researcher, an extremely passionate advocate for his patients, and a wonderful teacher, which I am sure you will know today. So this triple threat, the scientist, the educator, the physician, Dr. Maurer, please. We look forward to this.
Well, thanks for having me. It's really great to be here with everybody.
Can't
Brett,
hear you, Dr. Maurer. You're still muted.
oh,
Dr. Maurer?
Yeah, we could hear him.
Oh, we got him. Good.
can you hear me?
Yes.
Okay, sorry about that. Well, it's really great to be here with everybody. Appreciate having me, and Brett, kudos to you and your team for putting together a fantastic symposium, and kudos to my good friend Hanna for an amazing talk, as always. So it's an exciting time, I think, for patients with a transthyretin and amyloid. These are my disclosures. I truthfully am really
Can you
excited.
turn your volume up so I can hear?
Say again? I'm really excited about, obviously, the emergence of new and effective therapies, and obviously a little concerned about the potential for the cost of such therapies, I would say. You guys can hear me fine? Okay, just checking. So as has been talked about earlier today, the pathogenesis of a TTR amyloid is kind of shown here from work that seminally was done by Jeff Kelly, in which a transthyretin homotetramer dissociates into monomers that agglomerate into amyloid fibrils. And when they deposit in the heart, we've learned we call that transthyretin amyloid cardiomyopathy, a disease of older adults that we're focusing on today. And when it deposits in the nerves, we call that transthyretin amyloid polyneuropathy, typically caused, as we heard, by the Val30 MET mutation as the classic example. This is really, I would say, the quintessential form of diastolic heart failure. It has a phenotype that we've seen in which the heart is markedly thickened. There is almost no cavity or chamber. The end diastolic volume is really small. And what happens in patients is they develop over time, because of the infiltrative nature, progressive diastolic dysfunction and a reduced LV capacitance. And that results in upward shifts as shown here in the end diastolic pressure volume relationship. As a result, the end diastolic volume shown here declines, stroke volume declines, but ejection fraction remains preserved because that is the ratio of stroke volume over EDV. And with the decline in stroke volume, cardiac output goes down and so does blood pressure. And so one of the quintessential management strategies for these patients is a particular role for deprescribing. Many of the standard therapies that we use for certainly systolic heart failure, beta blockers and inhibitors of the ACE inhibitor system, ARNI therapy, are very poorly tolerated. And it's my clinical experience that many patients need these drugs withdrawn or deprescribed with a transthyretin amyloidosis, and they feel significantly better. Universal in patients with transthyretin amyloidosis is over time is atrial fibrillation. In large series, at least a third of the patients in the ATTR ACT trial, half of them at the onset had atrial fibrillation. And in our experience following hundreds of patients, it's, like I said, nearly universal. Anticoagulation is to be administered in all of these individuals in atrial fibrillation, irrespective of their CHADS-VAS score. And while international collaboration, I think, is necessary to really sort this out, at least at our single center experience, whether you received a NOAC or warfarin, there were no difference with regard to stroke or bleeding events. And so we tend to utilize a DOACs or NOACs in patients with amyloid and atrial fibrillation. The mainstay of therapy for these patients is the attempt to maintain euvolemia. Often they need a bioavailable loop diuretic, that is bumetanide or torsemide, because they have a gut wall edema and right heart failure. So Lasix becomes poorly bioavailable, and aldosterone antagonists in concert with the bioavailable loop diuretic are very important, ameliorating any degree of hypokalemia and helping with the right heart failure. We can probably touch in questions and answers about calcium channel blockers, but certainly the non-dihydropyridines like verapamil are poorly tolerated by such patients. And digoxin is thought to be relatively contraindicated, though I think that's probably overplayed. As you saw previously, over time, these patients develop hypotension and unfortunately may need support of their blood pressure with midodrine, and probably in question and answer, we can talk further. But pacemakers are not unusual. About a third of patients over time require a pacemaker. And there's very little role in my clinical experience for ICDs in these particular individuals, but there may be an important role for biventricular pacing when pacing is needed. So I think there have been a lot of changes in the understanding of this disease. As Maz highlighted, there's a change in the epidemiology. We now know it's not rare. We can diagnose it non-invasively, but the key, I think, change has been the development of effective therapies. And in this review that Maz, Rick Ruber, Martha Grogan, and I, along with Jeff Kelly, drafted, we described the targets of emerging therapies. So we can block the synthesis of transthyretin into the liver. We did that in the past with liver transplant, but now we have two therapies, patisiran and inotersen. We can stabilize transthyretin with FDA-approved therapy, tafamidis. We can consider diflunisal. And there's a new kid on the block, AG10, and those are shown here, interacting in the dimer-dimer interface and stabilizing the protein, preventing its misfolding and dissociation into monomers. And then there's the concept, which I won't touch upon a lot today, of removal of fibers. And earlier in the week, I think you saw some data from Rodney Falk talking about the approach using anti-SAP that's been discontinued. And there is an antibody against TTR by Prothena called PRX that's still in clinical development. I would say that the money for therapy is really upfront here in the realm of prevention, not waiting till the heart's chunked full of amyloid and trying to remove it with antibodies, at least at this point in time. So for patients who have transthyretin cardiomyopathy without a neuropathy, as shown in this diagram here, the clinically available options are really tafamidis and diflunisal. As I'll show you, tafamidis is FDA approved for this indication. We have convincing phase 3 data from the ATTR ACT trial, though obviously cost could limit access. And I'll touch upon diflunisal, which can be used off-label. It is a non-steroidal that also stabilizes TTR at a dose of 250 milligrams twice a day. And it can be used, in my experience, used cautiously, and particularly in patients who fit these criteria. That is, they should not be recently decompensated, they should have reasonable renal function and not be on high-dose diuretics. And we can talk further about its use in concert with an anticoagulant, but we've done that successfully for many patients for years. So again, these are non-randomized data coming from our group prior to the publication of the ATTR ACT trial, in which patients at Columbia who were receiving tafamidis as part of either phase 2 studies or able to access it from Europe, or patients that we prescribed diflunisal to, you can see live considerably longer than patients who were not treated with these agents. Obviously, this is not randomized, but when we controlled for all the differences between the groups, the hazard ratio is quite potent for survival benefit and foreshadowed, I think, things to come with regard to the ATTR ACT trial. So you've heard about the trial earlier this week. This is a phase 3 clinical trial performed in 441 individuals who had transthyretin amyloidosis. We used the original dose of tafamidis at 20 milligrams and a new dose of 80 milligrams. For the primary analysis, these two dosages were pooled. And patients, importantly in this trial, were on the study for 30 months, a fixed duration, and were offered entrance into a long-term extension study. So who did we study? These are individuals typical of what Dr. Hanna described, a 74-year-old, predominantly males, and we mainly studied individuals with wild-type disease. Those who had hereditary disease were mainly the VAL122 ILE mutation. As you can see, ejection fraction in this cohort was about 45% or some odd. They have significant increases in wall thickness of almost 17 millimeters. They have markedly reduced global longitudinal strains, markedly elevated biomarkers, including NT-proBNP is about 3,000 and positive troponins, and some of the lowest stroke volumes that you'll ever see in the arena of heart failure. In fact, their stroke volume indexes are in the range of 25. What's kind of unbelievable with this phenotype is that they actually are NYHA class 2. And I think it's important for us all to note, I used to not believe that they actually were NYHA class 2, but I think they are. And that's because this is a very slow and indolent disorder. And so we have a huge opportunity, I think, to identify people certainly even earlier than the subjects that were enrolled in the ATTR-ACT trial. The results of the trial using the so-called Finkelstein-Schoenfeld method were highly statistically significant, but probably the most important thing to note here was that the absolute reduction in mortality was 13%. And so as shown in traditional Kaplan-Meier curves, there was a mortality benefit that the curves seemed to diverge at about 18 months. But the absolute reduction in mortality portended a number needed to treat of about 7.5 patients to prevent 1 death over the 30-month time period, or 2.5 years. And there was also a concomitant 32% reduction in the risk of hospitalization per year, with a number needed to treat of 4 to prevent 1 hospital stay per year. So pretty potent effects. The frequency of cardiovascular hospitalizations in those who were alive throughout the trial was also reduced by about 33%. And the hospitalizations seemed to diverge, at least time to first hospitalization, at about a 9-month time period as comparison to the mortality benefit that was about 18 months. We had a key secondary endpoints in this trial, including functional capacity as measured by the 6-minute hall walk and the Kansas City Cardiomyopathy questionnaire to measure quality of life. And as you can see, tafamidis slowed the decline. It didn't make people better, but slowed the decline in the functional capacity or 6-minute hall walk, and the same thing with the KCCQ. I think what's emerging from the data, though, is that timing of therapy for transthyretin amyloidosis is really key. And this is a diagram from an editorial I had the privilege of working with Justin Grogan from UT Southwestern on. And I think important to just review. This is the duration, if you will, of cardiac amyloidosis. It's not really drawn to scale, but you can imagine that if you're an allele carrier of a mutation, or if you're in your 40s or 50s, you may start to develop myocardial infiltration of amyloid over time. And concomitant with that, there'll be an increase later on of your biomarkers, including NT-proBNP first and troponin later. There'll be an increasing risk of hospitalization, and obviously a slow decline in ejection fraction and renal function. And so there's a long, if you will, preclinical phase, and the New York Heart Class is highly concordant with the various staging systems. And what we're beginning to realize is that there's probably a period of time where you wouldn't want to treat an individual because they're too early and we're not sure they're going to develop a phenotype because we don't know the penetrance. There's an ideal period, if you will, of just right. And then there's a period where patients are too far advanced, at least for what we know of regarding stabilizer therapy. So this is my, if you will, 3 little bear analogy to the therapy for a TTR amyloid. Those who are too early, maybe asymptomatic allele carriers without a phenotype, and we'll show you a case. Those who are just right, mainly patients who are NYHA class 2, who have the disease. And then there are clearly patients who we didn't enroll in the ATTR-ACT trial who are too advanced and too late. So here's a subject who might show up in your office, who I think is too advanced for consideration of at least stabilizer therapy. He's 87 years of age. He's had 4 previous hospitalizations in the last 6 months, and he's non-ambulatory, frail, and he's in a wheelchair. He's hypotensive while taking midodrine. He's got a low BMI and a low albumin, so his modified BMI is markedly reduced. He's very, very volume overloaded, and he has a cardiorenal syndrome with a EGFR that is, markedly reduced at 21, markedly elevated NT-proBNP, and his ejection fraction is reduced, which is a late phase phenomenon. And the reason I say that he's too far advanced is such patients were not actually included in the ATTR-ACT trial. Everyone in the trial had to be ambulatory and be able to walk greater than 100 meters. We didn't include patients who were class 4 like this individual, or who had marked renal insufficiency or nutritional deficiencies as indicated by a low modified BMI. And while tafamidis across 11 pre-specified subgroups by the forest plots here was more effective, if you will, than placebo, there was one subgroup, those individuals with New York Heart Class 3, who basically had a slight survival benefit, a small subgroup, so the confidence interval crosses 1, but had an increased risk of hospitalization. And so I think we have to be careful and cautious about the application of therapies to individuals who haven't been shown in the randomized trials to benefit. Maybe there are subjects who are also at least too early for tafamidis therapy. Here's a woman who's 48 years of age. Her father actually died from the Val122 ILE mutation, and her mother is a carrier. And amazingly, this patient is homozygous for the disease, but she's relatively young. She has no apparent phenotype. Her exam is normal. Her EKG is unremarkable. Her echo is normal with normal strain and no apical sparing. We do see this phenomenon that the prealbumin levels are low in patients who have allele carriers of a mutation, but her cardiac biomarkers are also unremarkable. In this particular patient, I highlight the data that Rick Ruberg collected, and similar to data that I think Brett showed and Maz showed earlier. And that is that individuals who are asymptomatic allele carriers, or as Brett was showing, individuals who have carpal tunnel, if you leverage a PYP scanning, you'll see an increase in the HCl ratio or uptake, and it's one of the earlier signs of cardiac amyloidosis. So in this particular patient, we did do a PYP scan, both with a planar and SPECT imaging. And as you can see here, this individual still had no myocardial retention of technetium pyrophosphate, so there's really no evidence for a phenotype. At our center, we would offer this particular patient with counseling, though, therapy with diflunisal, but I don't think that there's any evidence at this point that, especially given the cost, that tafamidis should be applied because there's no clinical phenotype. And then I think there's the patient who's just right. Class 2 had, as we heard earlier, a biceps tendon rupture. This particular individual has increase in wall thickness, a preserved EF, a mildly reduced global longitudinal strain. And I would note a preserved renal function meets a non-biopsy diagnosis as having normal SPI and normal free light chains with a positive PYP scan, but did not meet, if you will, the criteria for the trial because the NT-proBNP on entry had to be above 600. I would suggest that it's a real mistake to delay therapy in an individual like this with proven wild-type disease while their BNP climbs. And probably one of the most underappreciated, underreported aspects of the ATTR ACT trial that Jeff Kelly elegantly described earlier in the week is this analysis in which of 441 people enrolled in the trial, as you can see, we only identified 37, so less than 10%, who were NYHA class 1. The majority of the patients in the trial were class 2, but the absolute mortality reduction, or I should say relative mortality reduction here, was 64% in those with class 1, 39% in those with class 2, and non-significant in those with class 3. So earlier the better for certainly stabilizer therapy. So as I've highlighted, I think there are 3 therapeutic options, really 2, but 2 different forms of tafamidis. There's tafamidis and meglumine that Jeff developed in his laboratory. The dose for a cardiomyopathy that's recommended is 80 milligrams a day. It's oral, there's no need for concomitant therapy, and it's approved now in US and in Europe. Tafamidis free salt is a new formulation that is once daily at 61 milligrams. It's biologically equivalent to the 80 milligrams, and the cost for both forms of tafamidis is quite high. Whereas, as I mentioned, diflunisal is a non-steroidal. Certainly there are potential side effects, needs to be administered with a proton pump inhibitor, but markedly less costly, and is something that we tend to administer to many allele carriers of a mutation if they're interested in the therapy. With the efficacy of tafamidis, there's now a whole host of options that are emerging, and I'll just run through these as investigational therapies. There is AG10, a new oral compound that's in a phase 3 trial, randomizing patients 2 to 1 with a similar approach to the ATTR ACT trial, looking at 6-minute hall walks and mortality and CV hospitalizations. There's the patisiran trial involving, or Apollo B trial, I should say, involving patisiran, that's randomizing patients, 300 of them 1-to-1 to patisiran or placebo, with a primary endpoint at 12 months of a 6-minute hall walk, and 2 new subcutaneous silencers that have begun to enroll patients. Jeff highlighted this earlier in his talk this week. This is what I think he would call a gift from Mother Nature. These are data that he developed in Science in 2001, emanating from observations by Teresa Coelho in Portugal, in which there were patients who had the V30M mutation, which is highly penetrant, but they had a second stabilizing, if you will, polymorphism in their TTR gene, T119M. And the more T119M you have, the lower the chance you're going to develop amyloid fibrils in vitro and in vivo. And this led to the idea that stabilization could be an effective way to treat this particular condition. AG10 is a new stabilizer that really mimics this T119M polymorphism, given its close proximity to other destabilizing mutations. And in a phase 2 trial that we participated in, published by Dan Judge and Jack, was an interesting observation that with AG10, TTR levels rose significantly. They seem to rise more in those with hereditary disease and wild type. And we have the same observation in patients with tafamidis. The construct here being that stabilization locks the protein together, and the current serological testing that's used clinically for measuring prealbumin measures intact tetramers, not monomers. The other emerging therapies are what we call silencers broadly. These are small interfering RNA or antisense therapy, and the construct is shown here. There's a production, as we know now, of a mutant or wild type protein that becomes unstable, deposits in the organ and causes the phenotype. And the idea and therapeutic hypothesis here is by reducing unstable circulating tetramers, we can prevent organ deposition, ideally stabilize, and maybe even recover the particular phenotype. These 2 agents, patisiran and inotersen, were published simultaneously in 2018 in the New England Journal in 2 different trials in which they showed, based on a neurologic impairment score, a significant efficacy in patients who had hereditary TTR polyneuropathy. And no surprise, such agents could be leveraged now for patients with cardiomyopathy. Notably, in the Apollo B trial, despite all the patients having neuropathy, a significant percentage had cardiomyopathy, and exploratory analyses showed that patisiran tended to prevent the rise in BNP and NT-proBNP that was seen in patients on placebo, suggesting a cardiac effect. And similarly, in a paper that Scott Solomon and others published in Circulation, there were significant beneficial effects of patisiran on cardiac parameters in these patients, with decreases, if you will, in wall thicknesses, differences in global longitudinal strain, and an enlargement of the ventricle that would be concordant with improved diastolic function. Similar effects, though be it maybe not as robust, have been seen with the antisense inotersen, where again, LV mass, wall thickness, and posterior and septal wall thickness both seem to be favorable in patients treated with inotersen compared to placebo. So for patients who have variant TTR, I would point out that these 2 agents, unfortunately, at least to date, silencers are only approved for patients who definitively have a neuropathy and a mutation. They can have a cardiomyopathy, but they must have a neuropathy. And so we tend to engage neurologists at our place, Tom Brannigan and others, to evaluate such patients if there are subtle findings. Patisiran is administered intravenously every 3 weeks. Rare infusion reactions are seen. Both agents, because they lower TTR and lower RBP, patients need to take vitamin A along with them. With patisiran, there needs to be pre-medications to prevent any of these infusion reactions. Inotersen is administered subcutaneously every week, but it has an associated REMS FDA monitoring because patients in the trial had rarely, but some had severe thrombocytopenia and glomerulonephritis. And again, while both agents are approved in the US and Europe, cost is exceedingly high for both. I'll just wrap up by saying I would think we're at, as Winston Churchill said, the beginning or the end of the beginning, if you will. We now have, at least that I know of, 4 phase 3 clinical trials for patients with TTR cardiac amyloidosis. The Attribute CM trial of AG10, the Apollo B trial of patisiran, and then Ionis's long-acting compound and, if you will, son of patisiran, vutrisiran, in the Helios B trial. So, I mean, I think that it's kind of unbelievable what we've collectively as a community and with patients' help been able to accomplish. We now have a clear biological understanding thanks to Jeff and his seminal work. And we're now kind of in this enviable position of potentially having several options. We have silencers for those with hereditary polyneuropathy, with or without cardiomyopathy, tafamidis in the US and now in Europe for cardiomyopathy, and whether combination therapy would be useful is up in the air. And the main message I want to give you, though, is that all of these therapies are much more effective when given early. So please go find patients and find them early in the course of their illness so that we can leverage these therapies most effectively. Thanks.
Well, let me just mute my thing. That was just great, Dr. Maurer. So we have lots of questions for this tetramer of talks that we've had this afternoon. And so I'm going to start off going a little bit backwards in time. Dr. Maurer, we're getting a lot of questions. One question was, and I think it's a more general or applicable question, there are some patients who are class 4 heart failure, or as you described, too late. So these patients that are too late, what therapy do you offer them? Do you offer them tafamidis? Do you offer them hospice? How do you manage those patients that have just shown up way too late, too many consultations late?
Yeah, well, it's actually very hard. I think, in most circumstances, you try to have an appropriate discussion with them about their clinical circumstance. I would point out there are certain patients who obviously, when they're optimized by a heart failure expert, may move from class 4 to class 3 and even earlier and could benefit. But I think it's a process. We've all learned to share decision making. No one wants to deny anyone what is potentially effective therapy. At the same time, I think tafamidis is in some ways amazing and great. It's got no side effects. Really prolongs life. But I think people do need to understand it's not a panacea. And setting patients up for the fact that staying the same is fantastic and would be what we're hoping to achieve, and even somewhat minor declines over time is considered success. So I think that's really an important discussion to have with patients and their families up front. Maz, I don't know what you do.
Yeah, same thing. I mean, unfortunately, a lot of patients still want the drug. The patient, 87-year-old, said they have a couple children that are pushing, saying, we don't care, we're going to pay for it, we have the money. And that's a tough ethical situation that we're put in all the time. I don't think that patient's going to be helped. And again, I know that you and Jeff Kelly have done some things where there may be some patients who respond better to stabilization than others. We don't really know why. We think at the 80 milligram dose we're going to have maximal stabilization, but there's a cohort in the Attract trial that did actually better. Some stayed the same and some still got worse, and I'm not sure how to identify those. But I think with Brett talking about, I think first of all, waiting until I think it's our EP colleagues now, when they're seeing failed AF ablations, they're seeing clues. They're now talking about it earlier. So now the wall thickness is 14 millimeters, not 19 millimeters. And with the carpal tunnel and the spinal stenosis and everybody's antennas up, if we can diagnose them when they're 13, 15 millimeters and their NT-pro is still under 500, I think that's where the holy grail is, which you stated. But again, these late stage patients, I agree with you, Matt. I think I feel really unethical sometimes, acquiescing to giving the medicine to some of these patients.
Yeah, I mean, the other thing I think you'll talk about probably tomorrow, just, in a younger patient who's advanced cardiac replacement therapy with a transplant is, an option. So Ron Watellis, I think, will talk excellently about that. But, I wouldn't deny some in therapy. I think people just need to know what they're getting involved in.
Yeah, that's been my one of my biggest challenges as well, which is what we're touching on here, which is, how do you manage the patient that you think really wouldn't have been in the Attract trial, and you know, I think it's reasonable to still offer them medication, but with the caveat that it may, you know, there isn't great data if they're class 3 plus, and if they don't necessarily meet the inclusion criteria, that they may not really have much or any benefit from it, and it does come at a pretty high cost. So just another question for the group here. Another thing that comes up a lot is atrial fibrillation in these patients. You know, we all talked about the classic teaching is to avoid things like beta blocker and digoxin and calcium channel blocker, but sometimes these patients do have atrial fibrillation and with rapid ventricular response, and they have you know, heart failure symptoms from that, or worsening symptoms from that. Is it okay to give beta blockers in that case? How do you manage that? We'll start, Dr. Hanna. Let's see what you.
Yeah, I think, you know, in patients with uncontrolled ventricular rates, you're between a rock and a hard place. And sometimes you may have to use some beta blocker. TTR patients will tend to, you know, tolerate that better than an AL patient. And then digoxin, you know, there's, you know, Martha Grogan published a patient population of AL patients who got digoxin, and we have already submitted ours, which was a mix of TTR and AL. And kind of that dogma that you can never use it, it's completely contraindicated because it's buying the fibrils. It's dogma. I mean, it was based on an in vitro study, and then there's case reports of toxicity, and certainly you have to be careful. But when you have no other choice and you need to get some rate control, you may have to use digoxin in those scenarios or try to get them in rhythm, but sometimes you can't get these people in rhythm very well. I will say that the amyloid heart, you know, often will need a higher heart rate to maintain cardiac output. So sometimes when you cardiovert the patient, they abruptly go down to 60 beats per minute. That can also be problematic. But I would say I definitely avoid calcium channel blockers. I wouldn't give Dolt or verapamil. Beta blockers, depending on the situation, DIGs, depending on the situation. And you'll see data that's being published that we used to have a very nihilistic attitude about doing AFib ablations. Some of these patients actually can have successful AFib ablations. And what Matt said about anticoagulation, regardless of CHAD score, is extremely important because they have a very high risk of thromboembolic risk. I probably answered 4 questions. You only asked me 1.
Great, fantastic. Dr. Maurer, maybe we can just piggyback on that a little bit as far as the EP comments here. You know, another thing that we see sometimes is left bundle branch block, and I've seen several of these patients get biventricular devices. Chronotropic incompetence is also a problem, and I think Ron Metellus will talk some about this tomorrow, but how do you think about that in patients with ATTR? If they meet criteria for some of these other devices, do you typically recommend they move forward?
I mean, I think the indications for pacing are similar to the, you know, ACC/AHA, HRS guidelines. You know, that's who gets a pacemaker. I mean, I think if you think about the physiology of this, you know, back to the AFib, it's actually pretty unusual for these patients, in my sense, is to present an AFib with a very fast ventricular response because they have concomitant conduction disease. You know, and so there'll be an AFib, but that's another marker that I don't know if we've emphasized a lot. You know, nuance at AFib, but your heart rate is 80, not 130. So I think if you think about the physiology, these people are going to become pacemaker dependent definitively. That's what happens over time. There'll be published data about that shortly. You know, and you know, if you have a RV lead-in, you're going to get desynchronous. You're going to take a ventricle that has a stroke volume of 35 or 40 mLs and probably lower the stroke volume further with desynchrony. So we've been upfront in patients who we know need a pacemaker, putting a BiV device in. I think that recommendation is not so firm. I think one thing we need, and this would be great for the community to collaborate on, is a small little trial in which we put BiV pacemakers up front and really determine whether or not it has clinical benefit. And there's ongoing discussions with some of the device companies to sort that out. But, you know, again, knowing that the patients can become pacemaker dependent, knowing that their stroke volumes are already low and desynchrony is going to be induced by RV pacing, it seems physiologically logical to think about a BiV in those patients.
That's a good idea. I have another question here for Dr. Eatman. This is a tough one. Can you comment on the rapidity of neurological progression in the setting of the T60A mutation?
That's a great question. Of course, you know, the T60A mutation is the most common mutation in the United Kingdom. It's more commonly associated with a cardiac phenotype, or historically thought to be a more cardiac phenotype. There were two cohort studies. One was in 2013, was in 2012. Both were in the UK. So the first study found that it was more prominent autonomic symptoms, postural hypertension or hypotension, diarrhea, constipation, nausea, vomiting, and that only a quarter of those patients had peripheral neuropathy, at least at the time of diagnosis, and that percentage didn't seem to change much over the time that they followed those people. However, the other cohort, which was admittedly much smaller, showed basically early and frequent association with carpal tunnel syndrome, even when compared to V30M, predominance of negative sensory symptoms, and very prominent neuropathy symptoms in many patients, and a relatively quick progression. They scored it with the Charcot-Marie-Tooth neuropathy score with the electrophysiologic correlation. So it's not entirely clear, you know, what the exact phenotype is. You know, it's not as well described as it is in V30M. It is clear that there are neuropathic symptoms, at least at the very least, a decent percentage of patients. But whether it's a kind of smoldering or slow course or a relatively quick course, there's disagreement in the papers.
I just
Dr. Hanna or Maurer, do you want to comment?
I mean, I'm not a neurologist, but you know, John Burke and others would always tell me that the progression of transthyretin polyneuropathy is, I don't know, 10, 15, 20 times faster than diabetic neuropathy. So, you know, if you're seeing someone who has a rapidly progressive neuropathy, probably a lot of heterogeneity, certainly something to think about. I neglected, I just want to highlight one trial that's available for individuals, open label at the Brigham. Actually, Rodney Falk is doing a, you know, kind of a open label inotersen trial. The beauty of that is patients get active drug and he's using historical controls. And I think as they indicated in the chat, they still have subjects, no cost for the patient. They get excellent care at a world-class amyloid center with Dr. Falk's group. So definitely would highlight that. I think there are many patients who don't want to be in a randomized trial, and they'll get, you know, a potentially effective therapy.
Fantastic. A question for Dr. Hanna here, and this is from the chat and it's from me as well. So, you know, we see these patients who have carpal tunnel syndrome, and you know, they have amyloidosis, or they have amyloid deposits in their tenosynovium, but they don't have cardiac or neuropathic involvement. How are you following these patients? How are you treating them? Are you treating them if they don't have overt neuropathy or if they don't have cardiac involvement? Are you giving them diflunisal? Talk us through that a little bit.
I mean, I think the first thing, once you detect that, you know, we have our own algorithm that we're following. We've gotten about 400 samples, and lo and behold, about 40 have been positive, so that 10% number. So what do you do when you find TTR in the tenosynovium? We talk to the patient, we get genetic testing, determine it's wild type hereditary, and then we like to get baseline testing. So as far as the baseline cardiac testing, we want to get an EKG and an echo with strain and an NT-pro and a troponin to get a baseline. And then if there's any abnormality there whatsoever, and even sometimes if there's not an abnormality, it depends on the willingness of the patient, we'll get a technetium pyrophosphate scan. So we're cross-sectionally trying to study the heart to see, is there any evidence that they may have subclinical disease if they're not symptomatic? And then we do ask them about neuropathy. Now, if it's a wild-type patient and their echo's normal, their EKG's normal, their biomarkers are normal, and there's no uptake on the PYP scan, then I say, look, you don't have any involvement in your heart. We're going to follow you. I'll see you once a year. We'll get an echo. And maybe every couple of years, we may get a technetium pyrophosphate scan to try to track when the first uptake starts to come. And again, this is a work in progress. I don't have longitudinal follow-up on these patients and going year by year and seeing when they become positive. However, about 15% of these people already have it in the heart. We've noticed when we've done the studies. If it's hereditary, obviously, and it's a very penetrant mutation, we may not wait. We have them see the neurologist as well. And we may offer diflunisal like Matt does, even if there's no clinical evidence. It really is patient by patient, but I think it's really easy to do. And as long as the patient, understands if they don't have it in their heart, they still need to be followed, because the whole purpose is pick it up at an earlier stage by longitudinally testing them. Whatever center decides how they want to do that is really up for grabs.
Well, that's let me just mute my thing. That's a great answer here. I'm going to ask another question of you all, something that we will probably touch base on tomorrow again too, is the concomitant diseases of aortic stenosis, particularly low flow, low gradient, and the presence of cardiac amyloidosis, and whether or not some of these really low gradients, even though sometimes it does augment contractility with something like dobutamine, how do you guys manage it? How do you guys screen for it? And do you offer TAVR in these situations?
Yeah, I mean, I think there's merging convincing data, and I was, have to say, I was surprised by our own data, which I sat on for about 3 years and was afraid to publish. But, in the Unveil trial that we did at Columbia, in which we found, as Maz said, 16% overall and 22% of men, when we looked at the outcomes of the patients who underwent TAVR, these were all, whether they had amyloid or not, they were getting a TAVR. They did not differ whether they had amyloid or not. And we thought that was interesting, and we weren't sure it was really real. They did have an increased risk, the amyloid patients, early on within the first year of hospitalizations for heart failure, which probably just is a reflection of the fact they're a little bit more difficult to manage. But there's a pretty convincing paper from James Moon and the rest in London that basically shows that, in the patients who got a TAVR, there was a, mortality benefit. So, I think you got to be really careful. You got to make sure it's real AS. It's somewhat complicated to figure that out with your valve team, but I don't think we should be denying these patients TAVR if we really have significant aortic stenosis.
Ibrahim, can I just ask Matt a quick question? So Matt, your patients come to TAVR. I saw you recently wrote a paper in EHA kind of saying that you wouldn't likely screen every single person with a PYP scan, but if they met various clinical suspectors like the diastolic function, the wall thickness, the age, the male's gender, you would. What is your current screening policy with respect to these elderly patients who come in for TAVR, particularly low flow gradient? I assume you're not scanning everyone.
Yeah, I mean, what we wrote in the Unveil paper was, with Becky Hahn, was we found that, if you looked at the, S wave of the, mitral annular velocity, and it was below 6, that identified everybody who had amyloid in this cohort. And you actually got rid of half the patients who you didn't need to scan. So then the yield would get up to, if you would, men, 44%, 32%. So that's kind of, everyone's getting an echo anyway. I'm not sure we know exactly how to screen. I think the bigger deal is, the other paper that's been published by the Europeans, and they have, 1,200 or some odd ATTR patients, is there were 22 patients who had AS with amyloid. So I don't think we should stop our looking for amyloid TTR patients with the aortic stenosis group. They're going to be a very small percentage of the pie, right? While there's overlap, and certainly the two phenotypes coexist, 98% of the patients who have TTR amyloid don't have concomitant AS. And I wouldn't want people to get the message that's the only group to look for. There's a lot of other people. You mentioned the AFibers, the carpal tunnel, the lumbar spine. We got to do something to identify these people earlier in the course of their illness.
I would agree with that and echo your comments. One of the things that we're starting to do more and appreciate it was, Tom Travel and others with their group from the UK have been using the TAVR CTs to use the Hounsfield units to get a sense of the extracellular volume and as a screening method to evaluate these patients for, to see if they have amyloid before they go down the pathway of one more test in their long armamentarium of tests that they have to do. So,
I think what we're all saying is there's going to be, in the next few years, a screening algorithm in various populations. The question is,
All right, so,
which one would that be?
oh, sorry, you cut off there for a second. Just a question for Dr. Maurer, and this was discussed a little bit on the first day, but given the cost issues of tafamidis, what do you think about the different doses that are available? 20 milligrams, 40, 60, 80 milligrams. You hear reports of people not taking the full 80 milligram dose in order to conserve pills. Obviously, the intermediate doses have not been studied, but what are your overall thoughts on that?
Yes, I think unfortunately cost is an issue for a lot of patients, and we can't, I think, sit and ignore it. The data that's going to emerge from the ATTR ACT trial is going to show that the 80 milligram dose wasn't necessarily superior, at least during the duration of the trial, as we all know, on hard endpoints, but on the biomarkers, it had a favorable impact compared to the 20 milligram dose. Better stabilization would be good. I think a majority of patients are stabilized at probably 40 or 60. So I think it's again a discussion with a patient of shared decision making, what they have to do. I prefer them to take one pill every 4 days as opposed to never taking it at all. In general, I'm not sure we know. Jeff showed a case of a patient, prominent individual who we did a dose ranging study with TTR kinetic stability assay, and basically showed that he was pretty stable at 60 milligrams. Mm-hmm. And I can tell you my longest surviving patient with TTR amyloid is from the phase 2 program, who's 96 now and has been taking tafamidis for 13 years. Wow. He happened to have won the lottery, and he's completely stable at 20 milligrams in Jeff's assay. So that could be something that people could potentially one day utilize to pick a dose. But, at this point, I would say, barring costs, try to stick to the 80 or 61 milligrams.
It's interesting. Obviously, more to come from that as far as the dosing.
Yeah, I'm not sure, by the way, if the sponsor is going to keep making the 20 milligram pills.
Right.
If they don't, they're going to make the decision for us, right? It's going to be 61 or nothing.
And in the last few minutes here, Dr. Hanna, why don't I ask you about your thoughts on combination therapy? Dr. Maurer spoke about these trials that are being done, these phase 3 trials with all the other agents. What do you think about combination therapy with stabilizers and silencers?
Yeah, I mean, it's intriguing. If you knock down the protein by 85%, which is what these silencers do, you still have TTR floating around, and you wonder if the remainder you can stabilize it with the combination do better than one or the other. We don't know. The studies that are happening, Apollo B and then Helios B with the Truceran, the sub-Q injection every 3 months, and then the Ionis drug, which is once a month. They're going to allow tafamidis, and in the Alnylam studies, there's going to be like a 30% cap on patients who can be on tafamidis, but you're going to have people randomized to placebo or the silencer. So you're going to have a cohort of patients on combination therapy. In the Ionis study, tafamidis is allowed completely. So, I don't know what the answer is going to be. Mechanistically, it would seem that it would be better, but I don't think we know. I think the hope is that in cardiac patients, the signals of regression that we saw in Scott Solomon's sub-study of Apollo and Merrill Benson single center trial showing there's actually regression of LV mass is intriguing, even by itself. So I guess the answer to my question is I obviously can't give combination therapy now, but I'm anxious to see in the next few years what these trials show.
Well, that was great. Wonderful set of 4 talks. I learned a tremendous amount. I think that the fact that there's so many people still here online watching means that I think a lot of people are interested in this and learning a lot from this. And with that, I'm going to wrap up today's session on TTR. And tomorrow we're going to go back to a lot of AL again, a little bit more complicated. Now that we've had our foundation from the last couple of days, we're going to get a little bit more nuanced, a little bit of a deeper dive. So make sure you tune in tomorrow, same time. We're going to have Dr. Angela Dispenzieri talk about AL amyloidosis, response criteria, maintenance therapy, and relapse. Dr. Ray Comenzo, relapsed AL, treatment options and novel therapies. Dr. Rhonda Vitellis will talk about other treatments in cardiac amyloid, specifically medications, rhythm management, heart implementation. So it's another day of blockbuster speakers. So please look forward to seeing you tomorrow. Make sure you tell your friends too. Thanks again, everyone.
Thank you.
With that, we'll end the meeting. Thank you. I want to thank all the speakers, Dr. Maurer, Dr. Hanna, Dr. Sperry, and Dr. Eatman for phenomenal talks. Thank you again.